All right, let's dive into our clinical overview of Japanese encephalitis. This is a really significant vector-borne viral disease, and as you'll see, it has some major public health implications we need to cover. So here's how we're going to break it down. First, we'll look at the virus itself, JEV. Then we'll get into the epidemiology and its global burden. After that, we'll unpack its pretty unique transmission cycle, move on to the clinical presentation, and wrap things up with diagnosis and management.
Okay, let's start at the beginning. Section 1, Understanding the Virus. So what exactly is Japanese encephalitis, or JE? Well, at its core, it's a vector-borne zoonotic viral disease. Now that's a mouthful, but it just means it jumps from animals to humans, and it uses an insect vector to do it. In this case, the culprit is the Culex mosquito. And what's really critical to remember is that its main target in the body is the central nervous system.
Let's take a closer look at the virus's structure. You're looking at JEV, which is a flavivirus. Now what that means is it's an enveloped virus. If you were to peek inside that envelope, you'd find its genetic blueprint, a single-stranded positive-sense RNA genome. This is all neatly packaged inside what's called an icosahedronucleocapsid. See those things sticking out on the surface? Those are glycoproteins, and they're absolutely key for how the virus latches onto and gets inside our cells.
So to get a bit more technical on its classification, JEV is a single-stranded, positive-sense RNA virus, and it's part of the flavivirus genus. Now here's a key point for your exams. There's only one serotype, but it has 5 distinct genotypes. Antigenically, this makes it a relative of some other big names you know, West Nile, yellow fever, and dengue. And why does that matter? Well, it has huge implications for diagnosis, especially when you think about potential cross-reactivity in serology tests.
All right, let's move on. Section 2 is all about the epidemiology and the global burden of JE. Let's track the history for a moment. The story really starts in 1871 with the first documented case in Japan. A big step forward came in 1935 when the Nakayama strain was finally isolated. But then you see this rapid expansion. By the 1940s and 50s, major outbreaks were popping up all across Asia. We're talking China, the Philippines, India. It really started to spread.
And the global burden today? It's still a huge problem. We're looking at an estimated 67,900 reported cases of Japanese encephalitis every single year. But the raw number of cases doesn't even tell the whole story. The severity is what's really stark. For patients who actually develop clinical symptoms, the case fatality rate is a staggering 20 to 30%. And it doesn't end there. For the people who survive, a huge portion, we're talking 30 to 50%, are left with severe, often lifelong, neuropsychiatric problems.
So where in the world is this happening? As you can see on this map, JE is endemic across a huge swath of Asia and the Western Pacific. We're looking at about 25 countries that are considered at risk. And these aren't small, isolated places. These areas are home to a massive chunk of the world's population.
Okay, let's zoom in a bit and look at India. This map from 2021 really highlights the incidence and shows us which districts are considered high priority. You can see the disease is endemic in several states, and you'll notice a pattern. It's particularly a problem in regions with a lot of rice cultivation and pig rearing. We'll see why that's so important in a bit.
Looking at the specifics in India, a few key things stand out. First, this is primarily a disease of children. The incidence is way higher in the 0 to 14 age group, about 5.4 per 100,000. We also see a clear gender split with a male-to-female ratio of roughly 2 to 1. Geographically, it's hitting rural and peri-urban areas the hardest. And it's seasonal, with peaks during and after the monsoon season, which makes sense when you think about mosquito populations booming.
And that seasonality leads us perfectly into our third section, the transmission cycle.
Okay, so how does this virus keep going? It's maintained in what we call an zoonotic cycle. Basically, it's a loop between mosquitoes, mostly the Culex species, and vertebrate hosts, specifically pigs and wild water birds. This ecological connection is exactly why JE is so tied to rural areas with rice cultivation. Those flooded paddies are the perfect breeding ground for the mosquito vectors.
Now let's talk about pigs. Their role here is absolutely critical. They are the amplifying hosts. What that means is they get infected and then they develop a really high and long-lasting level of the virus in their blood. That's viremia. This level is so high that any mosquito that bites them gets infected. So the pigs essentially act like virus factories, massively amplifying the amount of JEV in the environment.
Humans, on the other hand, are a completely different story. We're considered dead-end hosts. If one of us gets infected, we just don't develop enough virus in our blood to pass it back to another mosquito. This is a super important public health point. It means we don't contribute to the transmission cycle. You can't get JE from another person. And because of that, all our control efforts have to be laser-focused on the mosquitoes and the animal reservoirs.
So who are the main culprits vector-wise? We're talking about mosquitoes from the Culex genus. Specifically, you want to remember these three names: Culex tritaeniorhynchus, Culex vishnu, and Culex pseudovishnu. And where do they love to breed? Exactly where you'd expect: flooded rice fields, swamps, ponds, and irrigation channels.
Okay, we know how it spreads. Now let's get into what it looks like in a patient. Section 4, Clinical Presentation. This is probably one of the most important things to understand about GEV infection. It's like a clinical iceberg. The vast majority of infections, we're talking over 99%, are either totally asymptomatic or they just cause a mild generic fever. The severe disease, the actual encephalitis that gives it its name, that's just the tip of the iceberg. It only happens in less than 1% of infections. To put that in perspective, that's about one severe case for every 250 people who get infected. So for that unlucky person who does develop the full-blown illness, it usually progresses in two distinct stages. First up is the prodromal stage. This lasts about 1 to 6 days, and honestly, the symptoms are really nonspecific. You're thinking fever, chills, headache, nausea, vomiting. It could be anything. But then it progresses to the acute encephalitic stage, and this is where things get serious fast. We're talking altered mental status, convulsions, neck stiffness, and a really characteristic mask-like facial expression.
Which brings us to our final section. How do we diagnose and manage this? Okay, let's break down the case definitions, because this is key. First, you have a suspected case. This is purely clinical. You see a patient with an acute fever for 7 days or less, and crucially, they have some change in their mental status, maybe with seizures, maybe not. That's your trigger to suspect JE. But to get to a laboratory-confirmed case, you need proof. You need to back up that clinical suspicion with hard lab evidence. That means finding JE-specific IgM antibodies in the serum or CSF, seeing a 4-fold rise in IgG levels, or directly detecting the virus or its antigens.
Now, when it comes to management, this is the single most important thing to remember. There is no specific antiviral drug for Japanese encephalitis. None. So treatment is 100% supportive care. That's it. Your entire focus is on the basics, maintaining their airway, breathing, and circulation, your ABCs. It's about controlling seizures and managing intracranial pressure. It's about keeping their fluids, electrolytes, and nutrition in balance. And of course, controlling the fever. You're supporting the body while it fights the virus.
All right, let's wrap this up with a high-yield summary. If you remember nothing else, remember this. Pathogen, flavivirus, single-stranded RNA. Vector, Culex mosquitoes. The key animal hosts, pigs are the amplifiers, humans are the dead ends. How do you diagnose it? You're looking for IgM in the serum or CSF. And how do you treat it? Supportive care only. Nailing down these core facts is absolutely essential for your exams and for any clinical encounter you might have with Japanese encephalitis.